Hi, it's Damian and Rachel again. This is a second PAEDS review. Sorry it's been so long, but we've been making some little tweaks and little adjustments to get the best possible out of it.
Right, so given that we're coming into winter and we all know and feel that we've been seeing more and more wheeze in the department, we thought that we would focus today on our approach to wheeze in children at the Leicester Royal Infirmary. It's obviously specific to our department, but hopefully we can give you some top tips on how to manage wheeze in children.
So, first things first, there is a very clear and very good standard operating protocol about this. Please do look at Insights, download it in a quiet period and have a look. But the essence of our approach is to make sure at the outset that you're making a risk assessment or categorization of the patient. And the first thing is whether the child is in the mild to moderate category, and that's just essentially the children who basically look very well and have no additional severe symptoms or signs. The severe category are those who have specific respiratory rates for their age, or have low saturations, or using their accessory muscles. Now, just a little note here, please see the handy hints section of the guidance, because it's quite clear that accessory muscles are those muscles that join the rib cage to other parts of the body, such as those in the neck, and it's not about recession. Recession, kind of mild to moderate, is very common, especially in young children who have respiratory distress, and recession in itself isn't a marker of severity. And then the key features are those of life-threatening asthma, and they have some very clear signs, which are usually quite obvious. And obviously, those child must be responded to extremely promptly.
So once you've decided if a child's in the mild to moderate category or the severe and life-threatening category, you can then move on and treat them appropriately. Now, as you can see, in children, we've got really clear guidance on what the saturations are, and that's because it really makes a difference as to how you treat them, whether you give them nebulizers or inhalers. Now, as a general rule, in our department, it's been decided anybody who has saturations less than 92% who's going to need a nebulizer is best looked after in resus. This is to make sure that the most senior doctors are aware of them and that you have the nursing input that you need to look after these children well. So if your child's got mild to moderate, things I just want to point out to people are that after you've given a treatment, you need to go back and reassess. So you can give up to 10 puffs of salbutamol, but then you need to go back and have a listen and see what difference that's made. This needs to be done within 30 minutes ideally to give an idea of how well the child's reacted. The guideline then goes on to discuss things such as considering steroids in children who have wheeze. Remember again to look at the handy hints about this because we try not to give PRED to anybody who's got viral induced wheeze, and gives you other medicines that you might want to consider. If the child's in the severe to life-threatening category, then obviously they'll be treated with nebulizers because they need oxygen, and they, as I say, they need to be down in resus. We'll now move on to the second half of the protocol. Looking at this again, if we look at the mild to moderate first of all, you should really be able to tell within the first hour to 2 hours of a child's attendance whether or not you're going to get them well enough to go home or if they're going to need to come into CAU for prolonged treatment. If you can, try and identify this fairly early on in the journey because keeping them for 4 hours really isn't going to change the end outcome. So if they look like they need to come into CAU, let's get them up to CAU quickly, especially coming into the winter. The children with a severe to life-threatening continue to go through the protocol, but please make sure that you involve senior doctors as soon as possible and also consider phoning up to the PAEDS reg because you may well need an HDU or a PICU bed for this child.
Now, for those of you who work predominantly with adults, treating children with asthma is a little different because we try and get away with giving inhalers. And this is just a little reminder that those children who do have SATs above 92%, the evidence is quite clear that the inhalers are just as good as nebulizers. If you are worried that a child isn't responding in the way that you'd like them to, please just go and ask one of the seniors and they'll give you some assistance. For the children who are severe to life-threatening, who end up needing a salbutamol infusion intravenously, we have been working to modify are guidance to help the prescription of that medication and its delivery. And we've recently updated the pro forma again, so it's quite clear on the first couple of pages what the emergency department needs to do, and then the latter pages are about what happens on the ward. The example on this page is for children who are 2 to 18 years, and they're our biggest group that need intravenous salbutamol. And it demonstrates quite clearly at the top what the medication you need to draw up and how you need to dilute it. And then if you use the table to get the weight of the child, and then you can use the monograph to pick a loading rate and then maintenance if required.
Now, assuming that you've cured the child and they're ready to go home, we'd be really keen for everybody to go home with a children's asthma or wheeze action plan. We have actually looked at how well we are doing at giving these out since they've been introduced, and I'm pleased to say that we do seem to be giving them out to the appropriate children. This is a standard letter that goes to all parents. They get the top copy. The yellow copy is given to them to take to the GP, and the pink copy at the end is filed in the hospital notes. And it basically goes through what medicines they need to give and when. It ticks off which education we've given them and stop smoking advice. And all children who come to the A&E with wheeze need to see their GP within the next 2 working days for follow-up. Keep up the good work, and we'll be re-auditing this in the near future.
And finally, just a reminder that all wheeze is not necessarily asthma. If you're less than 9 months, and basically definitely if you're less than 6 months and it's your first presentation, please do consider bronchiolitis as a cause for wheeze, and there's a very good SOP on that, which we may cover in the future, but please do look up. And also, there is wheeze caused by allergies and other conditions, so please do have that in the back of your mind. So thank you very much for listening, and we'll get back to you with a new video cast shortly. As always, we welcome feedback on this approach, and if you do have suggestions or would like to get involved yourself, please do let Rachel or I know.
Thanks very much.
Goodbye for now.